Well, hi everyone, Jake here from IBPF, and I want to thank you all so much for joining us on today's webinar on the topic of a transformative approach to the assessment and treatment of bipolar disorder postpartum. And we're so honored to be joined by Dr. Verinder Sharma today, and he is a professor of psychiatry and has a cross appointment to the Department of Obstetrics and Gynecology at Western University, London, Ontario. And lately, he has devoted his research efforts to exploring the relationship between postpartum psychiatric disorders and bipolar disorders. So, Dr. Sharma, thank you so much for joining us today, and we look forward to hearing what you have to say.
Thank you very much, Jake, for the nice introduction, and hello, everyone. I am honored to be presenting on this important but relatively neglected area of research inquiry. So the title of my talk is A Transformative Approach to the Assessment and Treatment of Bipolar Disorder Postpartum. Okay.
And I do want to let everyone know that there will be a question and answer session at the end of this presentation. So think about your questions throughout, and you can drop them into the question box at any time.
And this is my disclosure slide. So first, I'm going to talk about the classification of postpartum mood disorders and or bipolar disorder, and then have a discussion about the impact of reproductive events on the course of bipolar disorder, especially in the postnatal period. And then we'll move on to the prevention of mood episodes in women with bipolar illness. And we know childbirth is a potent trigger of these episodes, but it also provides us with opportunities for early detection, diagnosis, and management of this disorder. And then I'm going to delve into the issue of insomnia. We know insomnia or sleep loss is an important and early symptom of the disorder, as well as a trigger. And then finally, I'm going to discuss our treatment approach, and that is really based on a recent study at our center. Postpartum mood disorders are generally classified into postpartum blues that affect about 50 to 80% of mothers in the first 2 weeks postpartum. And the symptoms include irritability, anxiety, mood swings, and increased emotional reactivity. These symptoms never last more than 2 weeks and remit spontaneously unless they are followed by postpartum depression or postpartum psychosis in some individuals. And then we have postpartum depression that affects about 13 to 14% of mothers in first year postpartum. And the usual symptoms include sadness, lack of pleasure, guilt, anxiety, sleep disturbance, thoughts of suicide, and fatigue. And finally, postpartum psychosis is a rare but serious psychiatric condition and often requires psychiatric hospitalization. It affects 1 in 500 to 1 in 1,000 women in the first 3 months postpartum. And the symptoms are a mixture of symptoms of depression, mania, psychosis, and disorganized behavior, cognitive impairment, and lack of insight. As you note from this slide, there is no mention of mania or bipolar disorder in this classification. So I see this as an incomplete classification of postpartum mood disorders, and I'm going to discuss some of the concerns that I have with this. First of all, the hypomanic symptoms, also known as baby pinks, are common after childbirth. Studies from several countries have shown that anywhere between 9.6% up to 49% of women have brief hypomanic symptoms in the first few days after delivery. And similar to the baby blues, these symptoms are transient. So the clinical significance of these symptoms lies in their association with postpartum depression in some women. And the second concern is that a postpartum depression is a heterogeneous entity. It can occur in women with major depressive disorder or in women with bipolar disorder. And this study from several European countries and Israel, it retrospectively evaluated women with bipolar 1 disorder, bipolar 2, and major depressive disorder for the history of postpartum depression, and found that approximately 1/4 of women had postpartum depression. And the women who had postpartum depression, they were more likely to be younger at age of illness onset, and had more family history of bipolar disorder compared to women who did not have postpartum depression. And women with bipolar 2 disorder were at an extremely high risk for having postpartum depression. So half of these women had a depressive episode after delivery, compared to about 22% in women with major depressive disorder. And similar to postpartum depression, postpartum psychosis is also a heterogeneous entity. And I wrote down what is in a name, and it seems there is a lot. So an episode of psychosis can occur in someone with bipolar 1 disorder during the depressed phase, or during the manic or mixed phase. Similarly, women with bipolar 2 disorder can have psychosis during the depressed phase of the illness. And we know that women with major depressive disorder can also have psychotic features. And I have also seen in our clinic some women with obsessive compulsive disorder who may have either absence of insight or delusional beliefs. And finally, there is brief psychotic disorder. And these are individuals who have a psychotic episode without accompanying mood symptoms. So in general, postpartum psychosis is really considered a variant of bipolar disorder, but we have to keep in mind that it can exist in the context of several disorders. What happened to postpartum mania? And that's how I became interested in looking at this issue, because in the classification, there's no mention of mania. However, this situation is very different when you look at the historical literature. For example, Esquirol in the 18th century, he described 92 cases of women who were hospitalized to a psychiatric hospital in the postpartum period, and 49 of these women had mania. So more than 50% of women hospitalized had a diagnosis of mania, and he considered it a good prognosis illness. And similarly in UK, in the Warwick County, 12 of 16 women hospitalized, this is 19th century, hospitalized, had a diagnosis of mania. So it is certainly not uncommon. My feeling is that some of these patients may be diagnosed with postpartum psychosis. So this is the DSM-5 criteria for postpartum mood disorders. It allows the use of the peripartum onset specifier that can be applied to the current or the most recent episode of hypomania, mania, or depression if the onset of symptoms is during pregnancy or in the 4 weeks following delivery. And there are concerns about this definition as well. Number one, the duration of the risk period is very small, only 4 weeks. We know that women remain at risk for either first onset or recurrence of mood episodes for several months. And the second concern is that childbirth triggers a variety of psychiatric disorders, not only mood disorders. And the other disorders include, for example, anxiety disorders, obsessive compulsive disorder, and eating disorders. Let's talk about bipolar disorder. Depending on the severity of mood elevation during acute episodes, the disorder is subtyped into type 1, type 2, and otherwise specified bipolar and related disorder, with a combined prevalence of 2.4% in the general population. Bipolar 1 disorder is equally common in men and women, as opposed to the two other variants that appear to be more common in females. In terms of the symptoms of bipolar 2 disorder, they are similar to symptoms of bipolar 1, but they are of insufficient duration or severity to cause significant impairment, hospitalization, or psychosis. And finally, we have the otherwise specified bipolar and related disorder. And these individuals have bipolar disorder, but they do not meet the criteria for bipolar 1 or bipolar 2 due to the sub-threshold nature of mood episodes. That means that a depressive episode less than 2 weeks duration and hypomania approximately 2 days duration. Bipolar disorder begins at a young age, and we know it tends to cluster during the reproductive years, likely due to the effect of various reproductive events. Many women have the onset of the disorder before or within 1 year of menarche. And then there is an association between age at menarche and the age at onset of bipolar disorder, especially type 1. We also know that women with bipolar disorder and early menarche, and in this study, it was classified around 11 years of age, are at greater risk of peripartum mood episodes than those with normal menarche or late menarche. And we also know that women with bipolar disorder are at high risk of exacerbation of mood symptoms premenstrually. And a prospective study that we did, 44 to 75% of women had these symptoms. Pregnancy has a variable effect on the course of bipolar disorder. There are some women who experience improvement, and in others, there is no change, meaning it is neutral effect, and yet others experience worsening of symptoms. So these findings show us that women presenting with who have bipolar disorder, it is extremely important to get information about the age of menarche and also the effect of other reproductive events on the course of bipolar disorder. And let's discuss the effect of childbirth on the course of this illness. First of all, childbirth seems to have a pathoplastic effect on the course of the disorder because women are more likely to have psychotic symptoms, mixed symptoms, and obsessions and compulsions. And we also know there are some women who have first onset of the disorder in the postpartum period. We really don't know how common that is, but so, for example, about 5 to 6% of women have first onset of bipolar disorder in the postpartum period. And depending on the criteria used, 15 to 50% of these women develop bipolar disorder. And then there are some women with major depressive disorder who experience diagnostic conversion in the postpartum period. In our study, about 6.5% of women experienced either first onset of hypomania or mania in the first 6 months postpartum. And who were these women? So women with a family history of bipolar disorder in a first degree relative were at a higher rate of converting to bipolar illness in the postpartum period. And we also know that a postpartum onset near delivery, soon after delivery, predicts conversion to bipolar disorder. The study done in Denmark using the Danish psychiatric register showed that 14% of women with the first time contact during the first month postpartum converted to bipolar disorder within 15 years, compared to 4% with the psychiatric contact related to childbirth. So in terms of the psychiatric contact, either it is outpatient contact or hospitalization. Women who have outpatient contact are at a lower risk of conversion compared to women who get hospitalized. And what's the postpartum relapse risk in women with bipolar disorder? This is a meta-analysis of 25 studies involving nearly 3,500 patients with 5,100 deliveries. And the study done by Dr. Veselu and his group showed that approximately 37% of women with bipolar 1 or bipolar 2 disorder had a relapse. Women who had a postpartum psychosis had a slightly lower relapse. And there was no statistical significant difference in the risk between women with bipolar 1 disorder or bipolar 2 disorder. And as expected, women who took the medication were at a low risk of relapse, and that is 23%, compared to women who took the medication, 66%. But let's not forget that in spite of taking the medication, 1 in 4 women had a relapse of bipolar 1 or bipolar 2 disorder. So we were interested to know what's the risk of relapse in women with bipolar 1 disorder. So the previous study did not give us the information as to what the rates were for individual episodes. So for example, we did not inform us what's the rate for mania or a mixed episode. So we recently published this study. We looked at women with bipolar 1 disorder, and the overall pooled prevalence was 39% of an episode of mania, hypomania, or depression. And among those who had a relapse, 38% had an episode of mania or a mixed episode. That means that approximately 1 in 7 women with bipolar 1 disorder have a manic or mixed episode. And this is very significant because the illness that's responsible for higher rates of psychiatric hospitalization, this is mania or mixed episodes. Women also get hospitalized for depression, but it is sometime later. Women with mania are admitted to hospital immediately after delivery. And similar to the previous study, we found that where there was no medication use, 58% of women had a relapse compared to about 26% where there was medication use. Let's look at the maternal and child outcomes. So, a diagnosis of bipolar disorder is associated with gestational diabetes, hypertension, and cesarean section. And then there's a high risk of suicide. And in terms of preventing suicide, we have to keep in mind that women remain at risk for suicide for some time. A study done in Canada, for example, showed that most of these suicides occurred in the final quarter of the first year postpartum. And similarly, filicide and a case control study from Italy found that of 30 deaths, 5 were within 24 hours, 11 within approximately 5 months, and then the rest between 13 and 96 months. So again, it tells us that when we are looking at women with bipolar disorder, our job does not end at 4 weeks. These women remain at risk for several years, several months, sorry. And then in terms of the child outcomes, there are higher preterm birth and low birth weight rates, which are the two clinically relevant predictors of long-term health for the child. And then there is the higher healthcare utilization and charges compared to mother-infant diets with and without other mental health diagnoses. Bipolar disorder is quite common in the postpartum period, but unfortunately, there's a lot of underdiagnosis or misdiagnosis of this condition. A large study, for example, from US, they assessed 10,000 women within the first few weeks after delivery and found that 14% screened positive for postpartum depression. And 23% of these women had a diagnosis of bipolar disorder. And this is a community sample. This is not patients who were seen in a clinical setting. And the other thing we have to keep in mind is that they used a rating scale screening to assess depression. These women were not interviewed they were not screened for bipolar disorder, meaning that the rates could have been higher than 23%. And the most common diagnosis in women who had a positive screen for bipolar disorder was bipolar 1 disorder, nearly 50%. A study done at our center showed that 54% of women who were referred to us for postpartum depression had a diagnosis of bipolar disorder. So the illness is quite common, but unfortunately, people are not regularly assessed to clarify the diagnosis. Another study by Dr. Freeman and her group, they noted that there was the onset at or before the age of menarche in all the patients that they saw, but accurate diagnosis occurred decades later. So these women unfortunately suffer for a number of years before getting the right diagnosis and appropriate treatment. And this is due to a number of factors. Number one, lack of awareness. There's a lot of awareness of postpartum depression, but we also know other disorders, including bipolar illness, are quite common in the postpartum period. And then there is the failure to elicit hypomanic symptoms. Unless specifically asked, women generally do not spontaneously report these symptoms. And the other thing is that the medication that we use, they are more effective for mania than for depression. And that means that they may mask symptoms of hypomania, and women really present to us with depression. And finally, there is the underreporting. And sometimes it's very difficult to distinguish, for example, the normal joy of birth from symptoms of hypomania. And we looked at the issue of bipolar postpartum depression. So the blue line, it represents unipolar postpartum depression, and the red line is bipolar postpartum depression. And just look at the discrepancy in the two disorders. Over the last several years, there has been an increase in bipolar postpartum depression. And if you consider the treatment, there are now several controlled trials for management of unipolar postpartum depression, but currently there is not even a single controlled trial of bipolar postpartum depression, not a single trial. So there's huge unmet need. And I'm going to spend some time discussing the nature of the peripheral trigger. If you're going to prevent these episodes, we have to know what are the characteristics of the trigger. And this is a landmark study by Dr. Kendall from Scotland, and they compared the monthly rates of hospitalization during 2 years prior to delivery and 2 years after the delivery. And before pregnancy, the average monthly rate was 10. During pregnancy, it goes to 7. And after the delivery, it goes up to 68. So 10, 7, and 68. And women were at those who were hospitalized for postpartum psychosis, their risk was even higher, especially among first-time moms. As you will note in this population-based study, pregnancy seemed to have a protective effect on the course of bipolar disorder. And then a much larger study, and again, using the Danish register, looking at the risk of first-time hospital admissions postpartum among first-time moms. And again, the risk was quite high in the compared to women who had given birth 11 to 12 months before delivery. First-time moms after the delivery were at a very high risk for first psychiatric hospitalization in the first couple of months in the postpartum period. And the risk was especially elevated during the 10 to 19-day period. And I want to share this slide. So the second characteristic of the puerperal trigger is that it is not, the recurrences are not true to type. And that provides, sometimes poses a challenge when it comes to management. So this is an individual, she started experiencing anxiety, premenstrual sort of worsening, treated with benzodiazepines, and that had first onset of obsessive compulsive disorder after her first delivery, treated with sertraline and antidepressant. There's a good response. And then developed depression for the first time in her second pregnancy, in spite of taking the medication. And the depression was quite severe. She made a suicide attempt, was hospitalized, and the sertraline dose was optimized. It was at that time that she was referred to our clinic. Since she was doing well on 150 milligrams of sertraline, we kept her on the same dose. In spite of taking the medication, she had a recurrence of depression. We added another medication, aripiprazole. There was a good response. But she comes back 3 years later, as you can see, cyclothymia. We try to bring her off the antidepressant. There is a mixed episode. So the diagnosis changed to bipolar 1 disorder, and initially presented with obsessive compulsive disorder, and is doing well on mood stabilizers. So the recurrences are not true to type. This is a second case. This individual developed trichotillomania, or the hair pulling disorder, coinciding with menarche. and develops first major depressive episode after her first delivery. And I saw her 9 years after her delivery. And by that time, she had continued to struggle with symptoms of depression and trichotillomania in spite of ongoing treatment with antidepressants. And I diagnosed her with otherwise specified bipolar and related disorder, tapered off the antidepressant, and used lithium. On the left-hand side, this is prior to the use of lithium, and just look at the difference. Within a few months, there's full hair growth, and she's taking great pride in her personal appearance and returned to work. And the hypomanic episodes were never more than 2 days. So somebody could argue this is really not bipolar disorder, but just look at the difference the treatment made. So let's look at the timing of onset of these episodes. And this is a study from UK of 127 women with postpartum psychosis. And 2/3 of the cases of psychosis began within the first 3 days after delivery, but they recalled having symptoms in late pregnancy. And the symptoms were feeling excited, elated, or high, not needing to sleep or not sleeping at all, being more energetic, more talkativeness. So postpartum, in that sense, is a misnomer because a large number of women have onset of these symptoms in the prepartum period. So if you're going to prevent these episodes, it's very important that we see them early on and monitor them for the emergence of these symptoms. And this is true of other psychiatric disorders as well. For example, postpartum depression, almost 60% of cases begins during or prior to pregnancy. There has been this sort of disturbing trend. This is the data coming from the nationwide readmission database in US of hospitalizations between 2016 and 2018. So on the left-hand side, the blue line, this is the rate during of postpartum psychosis during the delivery hospitalization, and the rate was 1 in 1,000. And if you look at the red line, that is 0.6 in 1,000 deliveries, and these are the re-hospitalizations. So on the right-hand side, it shows a large number of women get re-hospitalized within a short period of time. And approximately 42-43% within the first 10 days of leaving the hospital, they're back in hospital. And that risk remains elevated for some time. In this study, they looked at the readmissions in 60 days, but I know that women remain at risk even after the 60 days. So that means that when women are discharged, we have to make sure that they are on the right medications that will hopefully keep them well. And as I mentioned before, that women remain at risk of developing psychosis for several months, and especially during the time when the menstrual periods resume. And this entity called menstrual psychosis, described by Ian Brockington from UK, and described it as acute onset, brief episodes with psychosis, symptoms like confusion, mutism, delusions, hallucination, and periodicity. And I described a couple of cases associated with weaning. So interestingly, before the classification of postpartum disorders, people used to make a distinction between the postpartum period and the lactational period because women remained at risk for quite some time. And what are the predictors of perinatal recurrence, history of affective psychosis or depression? And in this study by Di Florio and her colleagues from UK, women with bipolar disorder who did not have previous perinatal mood episodes were at risk following a subsequent pregnancy, in that 7% of them developed a psychotic episode. Other risk factors are family history of bipolar disorder and or postpartum psychosis, primiparity, women at a very high risk for bipolar disorder, not only bipolar disorder, but other disorders as well. And then there is the sleep loss and insomnia. And finally, the use of antidepressants and psychostimulants, especially in women with bipolar 1 disorder. So I'm going to now spend some time on the issue of insomnia and postpartum psychiatric illness. So this is something that people have been interested in for a long time. And Hippocrates, in his fifth book of epidemics, included a case of a mother who, after giving birth to twins, experienced severe insomnia, and he noted much wandering at night, goes out of her mind again, then becomes irrational. So this waxing and waning of symptoms, no recovery of reason, speechless, and dies on day 17 from exhaustion. And then there is not a whole lot of mention of insomnia or sleep loss for several centuries. In the 19th century, Victor Louis Marcy from France described the case of a 26-year-old woman who became more active, developed insomnia, and started chanting incoherently 3 days after abruptly stopping breastfeeding a 14-month-old child. And then in the 19th century, Savage highlighted the importance of insomnia as a prodromal symptom of puerperal psychopathology. Robert Jones in 1902, almost universal early symptom of insanity. So the terminology has changed, but they use different terminology in those days. In puerperal cases, is loss of sleep. It is for this reason that early attention should be given to sleeplessness. And then Armstrong Jones in 1923, symptoms of insanity in puerperal cases almost invariably start with the loss of sleep, and as in all other forms of mental disturbance, this is the most frequent and distressing of all the symptoms. This is something I have been hearing from women for a long time. Unfortunately, our profession, I don't think, have paid enough attention to this issue. DSM-5, this is the current iteration, and it says that insomnia is more prevalent complaint among females than males, with first onset with the birth of a new child. And this, I think, is very significant. And a study done by Dr. Pellegrini from Italy and her colleagues, they examined the potential association between insomnia in the perinatal period and how it relates to the maternal and infant psychopathology, and showed that women are at high risk for depression, anxiety, as well as increased suicidality and distress in the newborn. So once again, it highlights the importance of detecting insomnia and then managing it in order to improve the maternal and child outcomes. So, as I mentioned before, there are challenges when it comes to assessing and managing episodes in the postpartum period, because the onset is early and is a rapid onset, and then there's a lack of routine screening to identify at-risk individuals. There's lack of controlled data. However, women are under the care of health professionals, and we can identify the modifiable risk factors. And finally, the duration of the risk period is short. I do not know of any period, any opportunity in psychiatry where we have the potential to make so much difference, because we know when it's going to happen and we know what the risk period is. And some of the things that we have to consider when it comes to prevention of recurrence is that there is a close temporal relationship of mania to delivery, then depression. And we talked about the issue of sleep loss. And it's easier to prevent hypomanic manic symptoms than depression. And in some individuals, if you prevent mania, it might prevent depression that follows it. And finally, the mixed episodes are more of a concern than pure manic or depressive episodes. And I want to briefly discuss this study that we completed recently, women with bipolar 1 disorder who were consecutively treated at my clinic for bipolar between 2020 and 23, and they were less than 32 weeks gestation at the time they were referred to us. A total of 12 individuals. It's a small sample size, but bipolar 1 disorder is a relatively uncommon condition. 5 of 12 primary parents, 11 had previously been hospitalized for bipolar disorder, family history in everyone positive for bipolar disorder. 4 individuals had a first or second degree relative death by suicide, and comorbid anxiety disorder in 4 women, and 10 had 1 or more mood episodes during the index pregnancy. And 4, we saw them for preconception counseling, and then they were referred back. So very severely dealing with severe bipolar disorder. And I'm not going to go into the details. So our approach was that if somebody is struggling in pregnancy, if they are on an antidepressant, taper it off and use the medication that promotes sleep. And in about 7 individuals, we used quetiapine, 6 olanzapine. If somebody becomes depressed, then use the medication that are indicated for bipolar depression, for example, lamotrigine. And we were really surprised that only 2 women had a relapse or depression. In 1, it remitted spontaneously. And the other one, as you will see, this is number 7, we wanted this person to come off the antidepressant, and she chose to stay on it, and she had a recurrence of depression. There were no hospitalizations, there were no suicide attempts, and these individuals were seen in follow-up for, in one case, 282 weeks, and some maybe up to 17 weeks. So very encouraging results. And the other thing was the amount of medication used was small, only few medications, and the doses were in very small quantities. Okay, one of the cases that I described in that study, I'm going to expand on this. So this individual, so this is the life chart. In the middle is euthymia. Above is mania, those red pillars and columns, and then is below blue is depression. So the first hospitalization in 2008, and then 6 years later, another hospitalization. These are the black columns. Additionally, there were 2 mixed episodes. So in total, there were 4 episodes of mania, 1 depression. And this person comes to us for preconception counseling. She was taking quetiapine, 200 milligrams. We kept her on the same medication. And she came back to us when she was pregnant. Her mood was stable, completely stable on quetiapine. However, we knew her risk of recurrence, even though the mood was stable, was extremely high due to the history of, number 1, primary parity, mania, preponderant illness. So we gave her olanzapine, to take immediately after delivery if she has emergence of manic symptoms. And lo and behold, those symptoms appeared on day 3. She took olanzapine. We had to titrate the dose, went up to a maximum of 15, and then she becomes depressed. And we waited about 10 days. The depression remitted spontaneously, and we tapered off olanzapine, and we saw her in follow-up for 8 or 9 months, and she remained symptom-free. So this is someone with ultra risk of mania they were very good. There was very good outcome. Okay, so proactive identification and management is the key. And women with bipolar disorder is a good idea. It's really essential to have pre-pregnancy counseling, and because it allows the identification of individuals who are at risk, the modifiable risk factors can be addressed, and the treatment individualized. And same in pregnancy, monitoring symptoms and measurement-based care. So you really have to use rating scales to assess the progression of symptoms in pregnancy and early intervention. Postpartum period, again, maximizing uninterrupted sleep, which can be challenging at times, and then the postnatal care. So in summary, women with bipolar disorder are at high risk of recurrence of mood episodes in the postnatal period. So I changed from postpartum to postnatal period. About 1 in 7 women with bipolar 1 disorder, they have a manic or mixed episode. Early identification and management of emerging symptoms in high-risk individuals is the key. And there should be a targeted approach to treatment. You have to know what the course of the illness is. If somebody has a lot of manic episodes, you really have to target symptoms of mania. And a collaborative treatment approach should be guided by a detailed understanding of the longitudinal illness course. This is extremely important. We cannot just focus on what happens during pregnancy or postpartum. You have to know the story. And the story in a number of women begins at a very young age. And unfortunately, they remain at risk after birth as well. For me, it provides an unparalleled opportunity to investigate the role of risk factors in triggering not only bipolar mood episodes, but also recurrences of psychiatric comorbidities. Why is it that some women develop OCD after the birth of one child, mania after the second, and depression after the birth of the third child? So finally, I would like to thank my patients from whom I continue to learn. Some of the amazing insights into this illness have really come from my patients. And also to individuals with lived experience for sharing their insights, like Diane Harwood, author of Birth of a New Brain, Healing from Postpartum Bipolar Disorder. Thank you. So I will be happy to have any questions.
Yes, Dr. Sharma, thank you so much for that presentation. And we will be moving on to the question and answer portion of this chat. So please drop your questions into the box. And our first question is, how would someone seek routine screening, and should they do that before pregnancy or during pregnancy?
So in my opinion, anyone during pregnancy or the postpartum period, if they have any psychiatric illness, they should be screened for bipolar disorder, because the risk of hospitalization is so high, and the risk for to the mother and the baby are so high. And as far as before pregnancy, unfortunately, the interest in bipolar disorder seems to be sort of diminishing, anyone who is presenting with depression, before you engage in treatment, is important to clarify the diagnosis. Similarly, anxiety, a common accompaniment of bipolar disorder. So I will recommend, before pregnancy, during and after pregnancy.
Well, thank you. And our next question is, what is a difference or differences between bipolar postpartum depression and unipolar postpartum depression?
So unipolar postpartum depression, these women have a diagnosis of major depressive disorder. And bipolar postpartum depression, these women can have a diagnosis of bipolar 1 disorder or bipolar 2 disorder. And then there's the third category, the otherwise specified bipolar and related disorder. In terms of these symptoms, they are similar. However, women with bipolar postpartum depression, they may be more likely to have mixed symptoms, more likely to have atypical symptoms. For example, hypersomnia, more slowing down, and increased appetite. Not only in terms of the diagnosis group that they belong to, there are differences in the symptom profiles of these two depressions.
Well, thank you. And our next question is that one of our audience members would like to know if you can elaborate on how pregnancy has a positive effect or can have a positive effect on some women with bipolar disorder, or protective effect, I'm sorry.
Yeah. So this really, the observation that some of these women, they improved during pregnancy, it piqued my interest in perinatal psychiatry, and that's the reason really I followed it, because we had a group of women who were very depressed before pregnancy, and during pregnancy, even though they were not taking medication, they were doing well. And I shared, a couple of large-scale studies that showed it has a protective effect. And it's not unique to bipolar disorder. We know a number of autoimmune disorders get better, improve in pregnancy as well. For example, multiple sclerosis, rheumatoid arthritis. And so it may have something to do with the immunological factors. But I want to emphasize that even though the mood may be stable and the person may be symptom-free during pregnancy, if someone has bipolar disorder, the risk in the postpartum period is extremely high. So that is something that we always have to keep in mind. The risk of suicide also goes down, is lower in pregnancy. The risk of psychiatric hospitalization is lower in pregnancy. However, it is not something that we see in every individual with bipolar disorder. And finally, I also want to mention that in some women, the positive effect of the pregnancy may be affected by the use of antidepressants. So, for example, in this study that I just shared, the moods of some of these women were quite unstable. So that's something that we have to keep in mind.
Thank you. So another question that we have is, what are some other symptoms besides insomnia for postpartum bipolar psychosis?
So as I mentioned, the psychotic episode, it can be in the context of bipolar mania, a mixed episode. Usually what we find is a mixture of symptoms. Sometimes, there may be depression, there may be manic symptoms, anger, irritability, and we see the waxing and waning of symptoms. So sometimes, the person is doing well, so-called sort of lucid interval, and then the condition changes very quickly. And then there are psychotic symptoms, hearing voices, seeing things, and some people have tactile hallucinations, gustatory hallucination, meaning pertaining to taste. And then there is the disturbance of the sensorium, the confusion. And so there are a variety of symptoms. And when we see someone with postpartum psychosis, it's very difficult to know what the diagnosis is, especially if this is the first onset. And sometimes over time, then the sort of diagnosis declares itself, then you know what we are dealing with.
Mhm. Well, thank you. And our final question of the day is, what are some common strategies that have been implemented to help women get uninterrupted sleep post-pregnancy?
So some of the strategies we have used is that in high-risk individuals, we like to involve, the partner, another family member, and in terms of the breastfeeding, pumping, should be a preferred way. And sometimes people sort of take turns, to allow the person to have more uninterrupted sleep. And the other thing is that if there are any medication that may be contributing to insomnia, you really have to, try to get rid of them. And when we're using medication to treat the condition, we have to be mindful that it does not cause excessive drowsiness at night, for example, or and some women find it difficult to wake up in the morning. So sometimes you have to start women at a low dose and titrate the dose depending on the response and the tolerability.
Well, thank you so much. And I'd like to thank everyone in attendance for joining us today. This recording will be available on ibpf.org and on our YouTube channel, International Bipolar Foundation. And if you would like more information on postpartum bipolar disorder, you can visit ibpf.org and search postpartum bipolar disorder in our search bar. And Dr. Sharma, I want to thank you so much. We are so grateful for you here at IBPF. And do you have any closing statements you would like to make?
Well, I'm going to close on a positive note. I think uh, we know who are the women who are at risk, and we know what the triggers are, and we have the treatment. So, in my opinion, this postpartum episode of mania, mixed episode, should be eminently preventable. As I stated before, there is no situation like this in the rest of psychiatry where we know what the risk is, and the risk period is very short. So yeah, but we really need more research. The study that we did is only 12 patients. We need more control data. So hopefully, this presentation like this, will increase the awareness that it is a serious illness, but it is a treatable illness.
Well, that is a good note to end on. So, Dr. Sharma, thank you so much. And everyone, I hope you have a fantastic rest of your day.
Thank you.